We're going to get started. Please take your seats. Well, welcome. My name is Doug Richardson, and I am the Executive Director of the American Association of Geographers, and we're absolutely delighted to hold a joint meeting here, our first joint meeting ever, with the International Society for Urban Health. For us, it's sort of a marriage made in heaven here, because within the field of geography, we've seen a very, very rapid uptake in geography and GI science in health applications, and we're now working heavily with NIH and many other organizations. And that sort of research has now moved forward to a fairly central place in, I think, in health research. So there's now what I call the kind of the spatial turn in health research. Sometimes we're working on spatializing health research and so forth. So there's a great interest back and forth, and for us to work with the International Society of Urban Health is particularly interesting on a different dimension, and that is we have 60-some specialty groups in our association. The largest one is the GI science one. The second largest one is the urban geography one. So there are a large number of our members who are interested in this combination of topics. So the sessions for this theme run all the way through the AAG meeting. We have 9,000 attendees at our meeting here in San Francisco. And the themed sessions of international geography, GI science, and urban health began on Wednesday of this week, and they run all the way through the two overlapping days of our two meetings, which is Friday now and Saturday, and then the IHU meetings continue on for another couple days after that. Notice if anybody here for the ISUH meeting who's registered or can attend any of the sessions at the AG meeting. Anyone who's registered for the AG meeting can also attend any sessions of ISUH. So one of the goals we had here really was to bring together international scholars, practitioners, and policymakers from different specialties, sectors, and continents to share ideas, findings, methodologies, and technologies, and to strengthen personal connections, which I hope we'll do in the reception which follows this event, and research collaborations, and to build research collaborations and networks. So this is really great. I want to take just a quick moment to thank so many of the people who helped put this together. This was a big task. There are a large number of coordination aspects and sort of scientific committee aspects that all have to be melded and merged. And I'd like to particularly thank Yonette Thomas, who, in addition to being just a wonderful person, is also a very talented all across the spectrum of geography, health, and so forth. And it was great that she has a relationship both with the AG and with ISUH, and she was able to be a real go-between and facilitator. I think without her, this meeting would have not happened. So with that introduction, I would like to let me also thank Ivey Boufford, who is the president of the New York Academy of Medicine, and they help, I guess, manage the ISUH. And it's been a pleasure to work with her, the sophisticated, wonderful, savvy leader, as we've worked together. And she, of course, had held senior positions in the Clinton administration in health. So with that, I'll be happy to introduce the president of ISUH, Shamim Talukder. Shamim?
Thank you, Douglas, for your nice introduction. And I also like to thank the American Association of Geographers to make this event as a mission of ISUH as an interdisciplinary organization. This event actually an example of the interdisciplinary collaboration between geographers, health professionals, practitioners, as well as civil society organizations. You may already know that ISUH established in 2002, and New York Academy of Medicine work as a secretariat of this organization. It organized several annual conferences in different parts of the world, and last year, this conference was held in Dhaka, Bangladesh. We are proud to organize that conference, and as outcome documents of that conference is the Dhaka Declaration, which is now as an advocacy tool to take forward of the urban health agenda within the Sustainable Development Goal, within the objective maybe with this association of geographers and other disciplines. ISUS has several executive board which accommodate different academicians, professionals, as well as representatives from different countries. As I said that, the world at this moment, more than 50% people are living in urban areas. And we are expecting that, 2015, it will be more than 70%. So in terms of, sustainable development perspective, there is no alternative to think about the health issues for the urban people. This is the ultimate goal for the sustainability or humanity or human development, that is urban health. So as a citizens of a country like Bangladesh, this is the country where the highest densely populated country. Our Bangladesh is a country of human beings. I just want to share with you that the perspective of economical development, the perspective of the development in terms of social, in terms of behavioral or other social determinants, it is a complex issue. We need an economical development. We also need an environmental perspective development. Recently, I was visiting in a slums areas, and I found there was a landlord who made these big slums. I asked him that, why did you make this big slums? Why did you not think about to make a real estate big building? It can give him more money. And he said that you don't understand the economy. Do you know the per feet, square feet rent in the slums areas, which is around 1,000 taka. But if you go to the real estate building, which is around 500 taka. And he said that economically, slums making is more benefit compared to making a good infrastructure or real estate building. So these complex issues we need to deal. These complex issues we need to deal due to we want to give a good environment for the people. We want a good outcome in terms of the health perspectives. As I said, the Dhaka Declaration, which really focused on the Sustainable Development Goals and habitat process. And we declared that we need to develop and implement a national level health policy that will integrate planning for the rural and urban areas. We need to recognize the importance of city and local level data and action to advance urban health. Support strong and effective governance to promote urban health, including clear roles of the city and local government, a strong public health infrastructure that can work in the partnership with other sectors to prevent, mitigate potential risks and benefit of health, of policies, programs, and investment across the sector. Finally, they establish and track national level targets and indicators that reflect the progress toward the urban health and health equities. I think that the conference, 2 days and next 2 days of the Urban Health, International Conference on Urban Health, give a pathway how we can really implement this Dhaka Declaration within this Sustainable Development Goal. Finally, as I said, that Bangladesh is a highly densely populated country, is a poor country. But if you look at the back in last 15 years, we had lots of success stories. Bangladesh became the champion in the health sector to reducing child mortality, maternal mortality by very small resources. So within the country, complexity, within a country, there's a lots of problem. Within the country, there are lots of good solutions. So we need to find out which solution is the best solution for our future. Thank you. Now I'd like to request Joe Boufford, the president of New York Academy of Medicine, to give his speech.
I won't be giving a speech, but anyway, good afternoon to everyone. Thank you. I just want to add a voice of welcome on behalf of the New York Academy of Medicine, which is the founder of the International Society of Urban Health in 2002, as Dr. Talukder said, and is now serving as its secretariat. I want to also sincerely thank Doug Richardson and his team for his support and partnership in the development of this joint meeting. We really do look forward to continuing to work with you, and I have several guardians that I'm sure will make sure that happens. Two of our board members are geographers, Gerard Salem from France and Blaise Ngando Yongsi from Cameroon, and of course the inimitable Yonette Thomas, who did bring us together and is also a board member of the ISUH. So they'll be watching us, and I look forward to doing many things together in the future. I'm very pleased to open this plenary session of our meeting on the theme of place and health. And we have some truly exciting speakers to give us really a context, I think, from the planetary to the earthly over the next 2.5 days. And we are going to do this as a little bit of a more formal session. So each of our speakers, I'm going to introduce each of them individually. They'll give their talks. We won't do questions and answers because we have a really nice reception waiting in the back of the room. And I know people have been stretching their brains all day. So we think this is going to be really a great way to end the day before we socialize together. The first speaker is Professor Sir Andrew Haynes, who's Professor of Public Health and Primary Care at the London School of Hygiene and Tropical Medicine and Chair of the Rockefeller Foundation-Lancet Commission on Planetary Health. He's been a member of many national and international committees, including the UN Intergovernmental Panel on Climate Change for the 2nd, 3rd, and 5th assessment reports, the WHO Advisory Committee on Health Research, Sustainable Development Solutions Network, and is currently a member of the Scientific Advisory Panel of the UNEP-hosted Climate and Clean Air Coalition. And he is going to talk to us about urban health in the Anthropocene era, insights from the Lancet Commission on Planetary Health. Andy?
Well, thanks very much indeed for that introduction, and it's a great pleasure and a privilege to be here to talk to you today. If you could put my slides up, please, that would be great. So what I'm going to do is to summarize for you very briefly the findings of the Rockefeller Foundation-Lancet Commission, which worked over a period of about a year, reviewing the evidence of the linkages between human health and global environmental change, and also attempting to articulate policies that might help to stabilize environmental degradation, but also to improve human health. So we started from an oversight, really, of an overview of the many changes that have occurred in human society over recent decades. And the first thing that really strikes you, of course, is the immense development over recent decades. Population has increased dramatically since the 1950s to 7 billion. Poverty has declined, absolute poverty has declined, although, of course, there are many inequalities still remaining, but nevertheless, the number of extremely poor people has declined. Life expectancy has gone up over 20 years since 1950, so it's now nearly 70 years on average. Water use has been going up dramatically to 4,000 cubic kilometers in order to grow the food to sustain this growing population in particular, but also for industrial purposes as well. And we've exploited much of the potential agricultural land that's available on which to grow food, which means that in future we'll have to make better use of the land that we have. And of course we've had a dramatic increase in energy use to power all this economic growth that has resulted in this tremendous change and advance in many ways in human society. But all this has come, of course, at a cost, and the cost has been very much to the environment. So we've seen dramatic decline in tropical forests, accompanied by, of course, dramatic declines in biodiversity. Water shortages have increased. Many parts of the world have been exploiting fossil water, aquifers, which cannot be replenished on a human timescale. So about 3 billion people live in parts of the world subject to varying degrees of water shortage. Some parts of the world, for example, in the Arab world, about 70% or more of the water resources have been exploited. The oceans are acidifying because CO2 is dissolving in the oceans, and that will have very wide-ranging effects on marine ecosystems, although we don't fully understand the implications of those. And temperature change, of course, more than a degree. In fact, if you just take the temperatures from February this year, on average, they're about 1.5 degrees over the pre-industrial era. So there's been a dramatic change in global temperatures. And although the negotiations in Paris were a very important milestone in reaching an agreement, they are inadequate to prevent dangerous climate change. So at the moment, even if all those agreements are implemented, we may be around 3 degrees warmer, perhaps by the end of the century, than pre-industrial times. And all this, of course, has been accompanied by an unprecedented reduction in biodiversity, over 100-fold greater than pre-human times. So all these changes, our concern was that they could threaten many of the advances in human health and well-being that we've seen in recent decades. And indeed, these changes are so dramatic that many scientists have christened our era the Anthropocene epoch. The term was first used by the Dutch Nobel laureate Paul Crutzen in 2000, but I think there's now a general scientific consensus that we are in an unprecedented geological epoch, which is illustrated on this slide that shows you how this very narrow band at the top is the Holocene period, which is the last 11,000 plus years during which humanity has been able to flourish, which is a quite benign period climatically. And as I say, the last few decades, we've seen these dramatic changes in the environment. And of course, we don't know what that means fully for human health, but we know that there will be many changes, adverse changes to human health as a result of this environmental drivers. So against this background, we coined the term planetary health. And in our definition, planetary health is the health of human civilization, of humanity, of our species, Homo sapiens, which now dominates the planet, but also the state of the natural systems on which our health ultimately depends. And it differs from the standard definition of global health because it tries to set human health in the context of finite planetary environmental boundaries. So let me very briefly give you a few headline messages as to what that might mean for health. Well, the first obvious one is the direct effect of a warming climate. And this slide illustrates the potential inability to work due to thermal stress. In the top, you can see the current situation where it's mainly green. So for most of the year, even in hot periods, even in the hottest months, people are able to work outdoors. But if you look at the bottom half of the slide, it shows you what will happen with 3 degrees global warming, and much of that now becomes red and orange. And that means that for those hottest months of the years, much of the potential to work outdoors will be lost. And so many subsistence farmers and other people who work outdoors that can't have access to air conditioning will not be able to work in the normal way. And that will have a profound impact on economic growth and the well-being of the poor. We know, of course, that cities have the urban heat island effect, and some studies, this is one by Howie Frumpkin and colleagues, has shown that the rate of increase of the annual number of extreme heat events over the last few decades in the most sprawling metropolitan regions in the US was more than double the rate of increase observed in the more compact metropolitan regions. So the urban heat island is a kind of fairly generic observation, but it also depends on the layout of cities. And so the way in which we design cities in the future will affect the degree to which we experience thermal stress. We also know that millions more people will be exposed to flooding, not just because of extreme precipitation events with climate change, but also because of sea level rise, summarized on this slide. The big red dots are where there's more than 1 million people exposed, because they're very low-lying, often deltaic regions where there's large urban populations. And just recently, 2 days ago in Nature, there was a very important paper published suggesting that the West Antarctic ice sheet is unstable. And if that melts, then that could double the rate of sea level rise by the end of the century. And if it melts completely, then it could result in perhaps 15 meters of sea level rise over the coming 400 years or so, depending, of course, on the policies that we put in place. There's growing evidence that some extreme events may be related to climate change, and this is a very interesting paper by Kelly and colleagues in the Proceedings of the National Academy of Sciences, which links the record drought in Syria to climate change and postulates that the record drought in Syria, which seemed to be a partial trigger for the current tragedy that's occurring in Syria, the risk was more than doubled by climate change. That doesn't mean to say that climate change was the only factor, of course, responsible for the Syrian tragedy. It occurred in a very divided and conflictual political environment. But nevertheless, it does seem to be playing a role in triggering an exodus from rural areas to urban areas, and is accompanied by unprecedented drying. It's fairly well understood, of course, that climate change is likely to reduce agricultural productivity and threaten crop yields at a time when growing world populations are demanding more food. But until recently, we haven't been aware that many other environmental factors as well could affect food production. So this is a paper by Sam Myers and colleagues looking at pollinators. Pollinators like bees, bats, butterflies, and other animals have a very important effect, of course, on many food crops, so they depend on pollination. And his paper suggested that if we lost pollinators completely, that there would be an extra 1.4 million deaths a year, partly from non-communicable diseases because of declines in fruit and vegetable consumption, but also because of malnutrition, because many crops that provide vitamin A and other micronutrients depend on pollination. We of course know that air pollution is a major killer. WHO suggests around 7 million deaths a year, both ambient, outdoor air pollution, that's 3.7 million deaths, which of course is a risk factor for many common non-communicable diseases, notably heart disease, ischemic heart disease and stroke, but also household air pollution, which of course results in very, very high concentrations, orders of magnitude greater than those experienced from outdoor air pollution, and spills over, of course, into the ambient atmosphere as well. So you can't add these two together, but there's some overlap between them, but overall about 7 million deaths. And they are linked, of course, intrinsically to fossil fuel combustion, but also the combustion of solid fuels by poor households in low-income countries. So there's many, many linkages between environmental change and the drivers of environmental change and human health. And what we want to do now, what I want to do in the concluding part of my talk, is just to outline one or two potential ways forward to face these dramatic challenges that confront us. So we identified three types of challenges: challenges of the imagination, conceptual challenges, such as the fact that we tend to use gross domestic product as the main reflection of human progress, when we know that it's actually a very faulty indicator of how humanity is progressing. A lack of knowledge, because there's been very little research funded in this area. That's changing now, but it's rather late. And of course, implementation barriers. There are major barriers to changing policies, partly because of vested interest, inertia, ignorance, and so on. So the future of planetary health will clearly depend on cities. Cities are the engines of economic growth and social change, with the annual economic activity of about $62 trillion, 85% of the global GDP in 2015. And they're also responsible for about 3/4 of global energy-related greenhouse gas emissions. And this slide just shows you an interesting comparison between Atlanta and Barcelona, which have similar populations, but very different carbon productivities. You can see that the transport-related carbon emissions for Atlanta a very sprawling city with a population of 5 million or so. Very, very different, almost an order of magnitude different from Barcelona, which is a much more complex city. So the way in which cities are laid out and designed has a very important impact, not just on the environmental threats that they experience, but also their environmental footprint. We also know, though, that there are many economic and health benefits from reducing air pollution through low-carbon policies, and these will dramatically reduce the threat of climate change, as well as improving health in the near term, the so-called health co-benefits. Climate change mitigation, by some estimates, will avoid over 1 million premature deaths per annum by the middle of the century due to reduced air pollution, some estimates even larger than this. And the marginal benefits of this avoided mortality, if you put an economic value on them, is between $50 and $380 dollars per ton of CO2, which actually exceeds the cost of abatement. So once you take into account the health benefits, then that can help to offset the costs of abatement. We know that urban transport is a very important contributor to greenhouse gas emissions, but also, of course, an important driver of human health. And this is just a summary of a study we did a few years ago, looking at the impact of much more sustainable transport, increased active travel, walking and cycling, and low-carbon transport systems, more public transport and less driving. And the graph there just summarizes the potential benefits to health and the costs that could be averted to the National Health Service of the UK if people walked and cycled in London, for example, or in urban England and Wales like they do in the city of Copenhagen. And it just shows you that we estimated about £17 billion, that's over $20 billion, saved, cost averted to the National Health Service over a 20-year period as a result of reduced diabetes, heart disease, a whole host of other conditions due to increased physical activity. We also know that exposure to natural environments can have some beneficial effects, particularly on mental health, and this is a systematic review of the literature. And you can see that from this vertical line is no effect, and you can see that the studies that have looked at mental health have shown that there's improvement in mood, in mental health from exposure to natural environments, a fairly consistent effect. Not so much, no evidence really of any change in physiological outcomes, but benefits to mood and probably to mental health as well from exposure to green spaces. We also know that green spaces can help to attenuate, to reduce the urban heat island, so planting woods, parks, and so on can reduce some of the thermal stress in cities, as indeed can ponds, lakes, and watercourses as well. So the way in which we design our cities can help to reduce some of the environmental stresses that people are going to experience increasingly in decades to come. Restoring ecosystems can play an essential role in regulating freshwater quantity and quality, and about a third of the world's largest cities source their clean water from protected areas, really emphasizing the importance of protecting the watersheds. Coastal cities, there are ecosystem strategies for protecting coastal cities from floods, at least to reduce the intensity of floods and storm damage, ecosystem restoration. Mangroves, for example, can protect coastal areas from storm surges. But it's also important to emphasize that badly designed adaptation strategies can also have adverse effects. So, for example, wetlands can host mosquito populations, which can transmit vector-borne diseases. So we need to build in a risk assessment to adaptation strategies. Housing can have many health benefits. For example, by implementing clean energy in households. The slide also illustrates how resilient housing can be built to withstand floods, and how we can design houses to reduce the ingress of disease-carrying vectors. So there's many things that we can do, even in low-income settings, to make housing more sustainable, lower environmental impact, and help to adapt to environmental change. We've already heard about the opportunity presented by the Sustainable Development Goals, and of course Goal 11 is around making cities and human settlements inclusive, safe, resilient, and sustainable. And this, I think, is a real opportunity for those of us interested in urban health to bring together the broad agenda of urban sustainability with health through indicators such as reduced air pollution, better access to transport, more resilience to disasters, and so on. So in conclusion, I think there's a great deal that cities can do to contribute to planetary health. They can make available, make accessible, more efficient public transport and active travel, promote universal access to clean, low-carbon energy, promote safe access to green spaces and ecosystem strategies for resilience, and improve housing, access to water and sanitation. And if we can combine these policies, integrate them, then I think there are real prospects to improve health at the same time as promoting environmental sustainability. And it's been very heartening to see that over the last year, there have been real signs of change in the funding community. We've seen a couple of major foundations come forward and put substantial sums of money on the table to address some of these planetary health issues. So, for example, the Wellcome Trust in the UK has pledged over $120 million over the next 5 years to address planetary health issues, particularly urban health and food systems. So although up to now we've had difficulty in attracting research funding, I think the situation is at last changing, and we can really see the opportunities for generating new evidence, new information to help us address the challenge of planetary health in the urban context. Thank you very much.
Thank you, Andy. That was a great preview of coming attractions for the next 2.5 days. So having read many of the abstracts that are being presented, it's very exciting. Now, I've just met Mei-Po Kwan today, but from everything I've been hearing the last several weeks, she seems to be the rock star of Geographers. So she's professor of geography and geographic information science at the University of Illinois at Urbana-Champaign, Champlain, I said Lake Champlain. I lived in Michigan, I should know this. And chair of the International Geospatial Health Research Network. She's currently editor of the Annals of the Association of Geographers and the book series entitled SAGE, Advances in Geographic Information Science and Technology. She's received many prestigious research awards, including a Distinguished Scholarship Honors Award from this august organization and a research award from the University Consortium for Geographic Information Science. So we look forward to hearing her remarks.
Yeah, thank you for the kind introduction. I am actually very excited to stand up here because I also helped to organize this Joy Symposium, Joy theme of between the American Association of Geographers and the International Society for Urban Health. And I've been reading a lot of abstract. Believe me or not, I read every single abstract for the AAG side and some of the ISUH abstracts. So it's indeed very exciting. And they want me to talk a little bit about how geographers can contribute to urban health. And I'm thinking, oh, 20 minutes, great, I can do it all here in 20 minutes. But I'm going to just trying to talk about a little bit about the connection and interaction, and using my own research to highlight a little bit of the research frontiers. The first slide I would like to say location matters, right? And context matters. And so when we research agendas that systematically incorporate spatial data and analysis into global health research, hold extraordinary potential for creating new discovery pathways in science. And I think that that's why we are doing this conference together. And I think that we look into the space and place that is happening, what is happening, and that also have very big implications for urban health. And in the first part of my talk, I want to briefly talk about the wonderful work that the AAG and NIH, the U.S. National Institute for Health, and the U.S. National Science Foundation. So we that have a health research initiative that and some of the key points, and I'm not going to talk about all that, don't worry, yeah. And obviously it's led by, Dr. Douglas Richardson. And then in this particular theme, we put together 120 sections and 500 papers all together. And some of the topics, that we touch upon is that how does the gene and environment interact with each other? Obviously, the genetic world, the genome, research is, genomic research is really big now, but the gene doesn't explain everything. And then when you look into the location, space, and place, the environment doesn't explain everything either. A lot of the time are the interaction. So we also look into health disparity. And this is the wonderful book that Doug and Yonette put together, Geography and Drug Addiction. And also some of the research on geospatial data confidentiality, and that how to address challenges for particularly geospatial data intensive research community. Believe it or not, in health research, we know very well about confidentiality. Health data is very sensitive, but also when you add the location to it, it's even more sensitive because you actually reveal where people live and who they are very easily. The data that I'm working on, and I have like 4 months tracking people, 4 months of GPS point, about 400,000 points in my database for one individual. And then when I visualized it, in the GIS, in Geographic Information System, do you know what happened? I actually can see where they're going. I mean, we are talking about displaying, retaining every single point, data point in space and time, 400,000 for one individual, and I can see a pattern. I'm like, oh, I'm not going to show you, by the way, I'm sorry. I can because of, and when I put a map on the top of it, and actually you can see the person's home, going to work, coming back from work, and then, so that's a very, very sensitive. When you add a map and a location to it, then everything becomes much more sensitive. And of course, when you look into attachment of the health data, then you don't really want to do that, I think. So I think that a major product out of the AAG NIH initiative is the free high-level NIH government officials and publish a science article with geographers and talking about a spatial turn in health research. And I think that already has talked about that. And very quickly to summarize, in this particular conference, and we have a lot of nice papers on reviewing the geographic patterns of disease, through mapping and spatial statistical methods, detecting disease clusters. So we know what the disease is happening. So, I mean, we are now can go from the planet Earth scale to some very local in the city. We can look into the space-time relationship between environmental risk factors and health outcome. For example, air pollution, what is the driver, what is the determinants, and modeling space-time patterns of disease diffusion. Obviously, there are lots of very major one like Zika and, like the chicken flu, and then they're going, how does the pathway and how do they diffuse in space and time, and looking into geographical access to healthcare-related facilities and protecting the privacy while using the health data. Oops, oh, I'm not. So this is CDC mapping spatial patterns of the disease on the heart disease. And then also, now we have a lot of medical research, medical records from hospital, and we can ask questions like, we have also locational information, is proximity to hospital emergency department associated with non-urgent use? This is a paper by Chen et al. And then, are there any health disparity between different groups of different degrees of, like, emergency department use? And they're finding by mapping, all this actually it's a lot of record, I think, 6 million, yeah. So analyzing that, and then they find out that maybe the travel distance from their home to the emergency, when they're increasing the distance, and actually they're more, they're less non-urgent emergency use of the hospitals. And then actually women and minority are having higher percentage of having the non-urgent emergency use of the room, and especially when they don't have a private insurance. Another research area that I would like to talk about is something that I have done some research on, and it's about the exposure and context research. We talk about from the previous speaker, we have learned pollutants, for example, in the environment is getting huge, and like how do we measure air pollution, water, noise, heat, radio frequency, electric and magnetic field, fast food, restaurant, and degradation. And they're all the negative in it. And then, but we like bypass active transport, we like parks, green, we like blue, we like grocery with fresh food and vegetable, and the social and economic advantages. However, like sometimes you will see your colleagues from Beijing may tell you that if you are in a bad pollution day, actually biking may hurt you more, right? So you don't want to bike, and then because you're probably breathing into more. And then you can also see that, there's cars that can filter PMs, and then, of course, those cars are more expensive. So the rich actually probably can be sitting in the car and having those filtering the PMs and driving to work. And sometimes we don't necessarily find the relationship between there's a park and people necessarily, and closer to the park necessarily, can encourage more physical activities. So now, what I want to see in the exposure research is like this, like we have lots of technology, geospatial technology, that equipped with a GPS that is location and time stamp, and then you can literally attach the contextual information to it associated with the individual. I think that one big concept obviously is the exposome, and then this is Kentucky, Lexington, Kentucky, and with the whole. With every 10 seconds, there's a data point. So this is 7 days, and the third dimension is time. And what this is that we can say that, when people are moving around, and then we can collect data using ecological momentary assessment. We can collect their stress level. We can collect who they're with, what they're doing, how much exercise they're doing. We can do quite a lot of those measuring, sensing, and also data collection. And then this is the web a million points is. But a more data doesn't necessarily mean that you have more knowledge and actually you know more, and you can discover more about their health and actually change their behavior. So I would like to say that what is very important in what the kind of research, exposure research that we are doing is that we can help to look into how do we challenge the prevalence concept theory and the methods in health research. For example, measuring distance. We can measure distance very precisely now, especially with GPS. We know exact the X and Y. We know the home address. We know where they shop, where they eat, and where they, do grocery shopping. However, a lot of the time, the simplistic proximity may not, reveal everything. For example, do people necessarily go to the hospital from their home? Maybe they get into an accident. So I think that there are a lot more sophisticated concept of so-called the access that geographers can handle and look into it. And WHO and then, bring out a very important point where people live affects their health and chances of living flourishing lives. So the residence is very important, and we always collect the home residence, and then we do a lot of geographical analysis. However, in a lot of the GPS tracking, we find is that the red, actually, I cannot really point to any of the screen, I'm sorry. So the red boundary actually is where the census tract of the person's home, and the green dot are the blue are what they think that is the neighborhood, the environment, relevant context, and the blue dot are where they actually perform, physical activities. So you can see that they don't, the space actually doesn't coincide. So that leads to what I'm thinking about. There's a lot of uncertainty in linking the environmental exposure modeling, to the health effects and the well-being. So we like to, think about environment and health goes hand in hand, and then we study the environment, we measure the environment, we measure the health effect and health outcome, and we can link them together. But actually, it's not as simplistic as we would think, and a lot of the time we can build environmental exposure monitoring, sensing, and GPS, location in space and time to building models like land use model for air pollutions. We have a lot of success. GIS can help us to build actually 3D models, indoor, outdoor for air pollution now, not just like two dimension, but we can measure what floor you are in actually matters for your air pollution. In Hong Kong, there's a lot of high rises, and then actually they measure each floor of the air pollution, so it's three-dimensional. However, linking to the models to the health effects are much more complicated, and then I would like to say that, for example, getting close to a fresh food and grocery store does not necessarily, get you more healthy food and a good diet. So we need to build more conceptualized models. And one of the major challenges that I would like to say is the uncertain geographic context problem. It's not just about how do you measure the scale and the spatial and how do you group the zonal unit, as we know, using the census block or the census tract or different spatial unit in different scale. But actually, it's the uncertainty in our spatial and temporal delineation of where we think the context is. We look into this particular graph, and then the tiny little circle, at the lower corner left, and it's actually, somebody said that this is highly relevant to her behavior at teenage girls' risky sexual behavior. This is her grandmother's house when she went to play basketball when she was small. So you can say there's a temporal spatial uncertainty that the space is not her home area, it's not her own home neighborhood. It's not even her current residence. It was quite a while ago when she was little and then playing in the grandmother's house. And I have a project, like in Tijuana, and I walk every single street of the red light district and looking into female sex workers and how do they affect, their risky behavior and HIV infection. And I found out that actually they are organized by every street, and then they coordinate by where their hometown, where they're actually from in different parts of the Mexico. So this is very spatially, very uncertain that how do we delineate the appropriate spatial context, which part of the town or which part is the neighborhood or which part is the context that you are actually relevant to your behavior. Then there's also a temporal uncertainty because cancer doesn't develop in one day. And we look into, like a lot of the time of the psychological, medical, hospital record. And it's not the immediate environment that put people in stress. It's actually a few hours prior and consistently in another project that is like 12 hours. So you can get very different contextual units, false positive, when you look into environment and health, can be false positive or false negative, may not have any a relationship. So the residential neighborhood may be not accurately represent the actual area, maybe just one of the contexts of the health behavior and the outcome. So it's highly complicated, and I think geographers, among many of the experts here, can actually help to contribute theory on the environment and on concepts and on the exposure and context. But what I would like to point out is that right now, the technology does help us on the dynamic conceptualization to look at the actual spatial temporal configurations of the exposure, and we can individualize all these measures and on different subjects. This is, on the social network and how the gene and environment interact, and then we don't necessarily have to look into the current person, but maybe when they were exposed in the mother, when the mother was pregnant. So activity space is another concept, and Los Angeles study. Then one of the construction of that is that we go beyond just the residents. We look into other places and measure them. For example, in the Los Angeles study that I did with my collaborators, and we look into the home, work, and church location, a third location, they go and the grocery, and non-residence child, and we approximate with a standard deviational ellipse. We can also do kernel estimation, and then which is like each grid cell has a contextual influence on each others. And we can buffer the GPS track. We can superimpose what is so-called the social degradation, and then look into how that is their environment. And then in the Baltimore project, that when we look into tracking of people in the environment and they move in the urban drug misuse, again, this is the first 20 subjects that we use, and then average, we got 400,000 points of GPS points. And then what we visualize in the space-time path, and then, by the way, this is the third dimension, is a time, that we are actually looking into buffering their home location, going to do the ellipse, like approximating the activity space, the daily life that they're going, and also using kernel estimation for that. And then what we find out, actually, by using different measures, we got very different answers on each of the measures. That is another uncertainty that we are facing when you actually look into the different delineation in space, then you're actually getting a different answer. So then how do you actually find out what is the neighborhood? How do you construct them? By the way, this is real GPS data for like 4 months of tracking everybody, every second, every like whenever they move, and then what we know is that when people move around the city, we need to use a different measure. But if they're moving not just within the city of Baltimore, maybe that all the measures are pretty similar, and there's different configurations. And then the pair t-tests, about the correlation are pretty much very strong. And then another project in Mexico, I think we got pretty similar on the female sex worker project. And then finally, I just want to say that we have a lot of contextual variables now, and got more than 76 physical environmental factors in the Baltimore project, and social environmental factors, and this is just some of the example. And what we do is that, we go for supercomputers and say, why? Because I couldn't open the file, it's too big. Yeah? So people yelling, noise, and then, so again, then how do you manage all this contextual influence? Because we are so used to say that, the air is polluted and people get stressed, it's green, and because our remote sensing images are saying it is. But actually, there are a lot more complications in the environment that we can study. So what my collaborator and I propose is that, by the way, this is three-dimensional. Again, it's our three-dimensional movement in space and time of the people. The third dimension is a 24 hours time, and the 2-dimension is Portland, Oregon. It's a GIS construction, and people just moving around, except you can only go up, because we are only getting older every minute. So this is a movement. It's like a fish tank. People swimming. The fish is swimming in the tank, except the fish are swimming up. Yeah. And so what we propose is that, in the Baltimore project, we actually find out that, the drug craving and drug usage and drug misuse happen in the most relevant environment is happening 12 hours before, consistently. Remember, we have all these GPS points, about 4 months of them, tracking them every 10 seconds. And this 12 hours actually is important, because if we are measuring just the immediate environment, the place, and the space, that we actually may get it wrong. Again, that related back to my uncertain geographic context problem. You may got a false positive or false negative of association between the environment and your health outcome. Oh, I'm sorry. Actually, I'm timing myself. Yeah, I'm a time geographer, so I'm very sensitive to time. Every single second counts, so the chair don't have to worry. I always time myself, yeah. But I think that you might be so kind to let me just finish this. And so this is why I do space-time, right? You know why. And then what I'm trying to say is that, what we really need is to identify the true geographical context in both in space and time. What is important? The psychiatrists mining the big data, and we are looking into the GPS tracking of all these drug users, and they are, consistently telling us a pattern is that not the right, exactly, the immediate environment where they're taking the use, or even when they're stressed, or when they're craving for the drugs, and actually it was before, like the environment before. And then we find that there's a relevant space and relevant place. And then the environmental factors socially and physically is not what we're thinking. We would think that, if there's a police, I feel safe. But in my female sex worker project, when they see a police and they feel very frightened, especially they don't have a license to perform female sex work. So I think that this is, so what we propose is again, like some GIS environmental cube, looking into dissecting, like many factors. By the way, remember, I couldn't open my file in my computer, and then, so I got to my colleague working in the supercomputer center and processing all this. And then we are looking into many environmental factors and trying to see in what space and time that this actually can be better, looking into the tracks of people moving. By the way, the third dimension, again, in my construct, is, again, the time dimension. It can be a daily life. It can be a light course, by the way. I mean, both people have been working on this and trying to summarize. And lastly, I just want to say that, like, we don't understand everything just by looking into where people go, but maybe more importantly is where people don't go, and trying to understand why they actually feel stressed or being sick. So this is go back to looking into narrative combined with mixed method, and looking into the places, by the way, the green and the blue are the GPS track where people go, but the red are the people fear to go. So this is, we can get it from the geonarrative, which I do it in the Mexico, and people are saying that they feel fear when they see police, and then, they may have a harassment and violence against the woman who is performing sex work. So I think that would actually make them not going to go for the resources they need, and that does have a higher risk of HIV infection. So lastly, I think that big data does not necessarily better, but we need big ideas, relevant data, causally relevant spatial temporal context, and then we can look into all kinds of research challenges that I think that for the next few days that we'll be collectively looking into together, yeah, and especially many of the wonderful presentations that I'm looking forward to. Thank you.
The variety and complementarity is amazing. I think it's going to be an exciting couple of days. Our final speaker in this plenary session is Alex Ross. He is the director of the World Health Organization Center for Health Development in Kobe, Japan. He's a public health policy expert trained here in California, UCLA. Prior to his joining the center, he served as director for partnerships at WHO headquarters in Geneva, and as senior advisor, various senior advisory posts to the director general. Before joining WHO, he served in senior positions in the UK Department of International Development, as well as several US government agencies. And he's going to tell us about a brand new report that's just out this week, and is getting its official launch tonight here with you, the Global Report on Urban Health, Equitable Health and Healthier Cities for Sustainable Development. Alex?
Controls it. Just don't press back. Forward is fine. Just forward. Okay, great. Can I close this? Okay, great. Thank you very much, and good afternoon, everyone. It's not every ISUH that we can actually say that we're launching a WHO Global Report, WHO Habitat Global Report on urban health. First of all, a great deal of thanks to Dr. Boufford, or Joe, I'm going to go to first name basis very shortly, to Doug Richardson, Ionette Thomas, Shamim, of course, and historically to David Vlahoff, because we've been involved in these ICOH conferences for over a decade, and when they first began. And this is actually an extraordinary moment, whether you realize it or not. It's the first time we've actually had the geographers with the health people. And I think this is a wonderful underpinning for the fact that this is about place and health. And hopefully this is a trend that will continue, but I just wanted to recognize the importance of this particular moment, and it's thanks to the folks that I've just mentioned for helping bring us to this point in time. I also like to ask Amit Prasad and Paul Rosenberg just to stand up for a second, because as I describe this global report on urban health, they're the ones who've been working with me on my staff to help put it together. So you can ask them the hard questions afterwards. But this is really, as you've already heard from Professor Haynes, Professor Kwan, is that this is actually a decisive moment in history. We've heard a bit about the planetary side of things, but why urban health? Urbanization and urban as a setting has not really been at the center of global health discussions nor global development really for quite some time. And I think this is what underpinned our desire to do this report 2 years ago, which is actually the second report. The first one was in 2010 when we collaborated with UN Habitat to launch the Hidden Cities Global Report. And it was the first time that we could actually put forward an understanding about health inequities and the importance of urban health and health inequities together to achieve health outcomes. And underneath that, to also to begin understanding how we needed to work together with different sectors to actually make a difference. And then recognizing that at that moment in 2013, roughly, that the SDGs were coming, and you're going to hear more about this in a moment, that this is actually kind of that perfect storm in a sense of a lot of different factors coming together. But also, why urban health? So consider that in 1900, 10% of the world's population lived in cities. Today, it's 54%. And in 2050, it'll be 67%. But also recognize that the world's population will increase from 7 billion to 9 billion from now to 2050. 90% of that growth in urbanization from 54 to 67% will be in cities. And actually, it's 90% of that growth of that population, will actually be in that urban setting. So we have seen this fundamental shift in world history about more people living in cities. So it's where they live, where they work, and this is actually key. Another aspect is a fundamental issue that we have roughly about 1 billion people living in urban slums today, which will double by 2050. So you have 2 billion people living in urban slums. Again, all of that being that growth in the urban environment. And that's a very dangerous situation, as we saw with Sao Paulo and Istanbul and some of the disturbances in the Arab Spring even, where we cannot take for granted what that actually means for social stability. But also a fundamental premise, as you've heard, is about economic productivity, that cities is that economic engine. But the other side is that cities compete to attract talent and companies to be livable cities. You cannot do that without addressing the fundamental health issues and the productivity of individuals and of communities together. So this global report on urban health, which is 240 pages long and has now been on our website and is loaded up on the conference website as well. Hopefully I get the right one here. Documents and brings together a synthesis of some very important data, but also some very important solutions. And so this tipping point in this remarkable environment right now has been ushered in by the Sustainable Development Goals. And the SDGs create something also politically that's extremely important. It has put equity at the front of the agenda, whereas the MDGs did not. And that has also an implication for understanding it, measuring, and acting on those health inequities. And then you could couple that across the different sectors and health issues that we've heard. And when we bring together the two goals, number 3 on health and number 11 on the urban environment for the very first time, so this is also going to be a very fundamental shift, because cities will now, and countries will have to take actions and be accountable for some of the data that will emerge back to the global community. So having this there is become a new opportunity. And within that context, oops, I was told not to go backwards, but hopefully this, all right. I can't go back, right? Okay, thank you for that. One button, there we go. What this report does is, as you'll see in a moment, is not only to document the equity issues in the data and their relationships, but also to begin to understand the relationships between the different indicators, the different targets, and the different sectors that represents for the opportunities to take some action, whether it's transport or the environment, or air pollution, universal health coverage, non-communicable diseases, housing, and so on. So environment, of course, is a very important part of this, but there's the entire set of issues around risk factors for NCDs, for communicable diseases, as you will see in a moment, around Ebola and Zika, for instance, or dengue for that matter, or disasters, whether it's the flood or whether it's an earthquake or a tsunami. These are all the types of issues that they all interact. And this is actually a very important aspect for planning and for thinking as we proceed. And so as the report is organized, as you will see, is that we have 3 key sections. One is actually thinking about the nature of the issues themselves and looking at it from the SDG standpoint, as well as universal health coverage, which is a fundamental new approach that's part of SDG 3, and it has to do with both the coverage as well as universality of all the people being covered for health services and also avoiding financial hardship. and then looking at the different communicable diseases and non-communicable diseases, but this is actually helping to set the tone. The first section provides a significant snapshot of the infectious and communicable diseases, of the non-communicable diseases, nutrition, as well as water, leading into the other issues of water and sanitation, which should be in section 2. But the vision for healthier cities is to understand the epidemiology that drives the individual needs in the different conditions, but also their risk factors. Now, a word about the WHO Center for Health Development that Joe just mentioned is that it's a bit of a think tank within WHO, and it has a global responsibility. It's in Japan for historical reasons because of support from the local government. But we have been using a determinants basis ever since we were the knowledge hub for the Commission on Social Determinants with Professor Sir Michael Marmot. And ever since, that's over the last decade, we've been leading WHO's work and thinking about these issues. And it has been driving this understanding that it's not just the diseases, but what are the determinants that are driving some of the patterns and where we can actually take the actions forward. Around nutrition is a very important issue because this has often been kind of ignored, but as you will see, this report presents a number of different both evidence but also some solutions about thinking about nutrition and food from very different perspectives, that we actually have a dual challenge or a dual problem of both malnutrition and obesity happening at the same time. And linked to that is urban food agriculture, but also looking at urban food deserts and a whole set of issues that are actually coming together. And I think this report tries to synthesize a lot of that information in one place so that it becomes the framework for thinking ahead. The second section of the report is about planning cities for health, or thinking about place and health as the theme of this conference. And there we explore from a number of different sectors that you'll see in a moment, both the solutions and the opportunities for action, and some of the evidence that we've actually really synthesized from a number of different sources to look at the opportunities. And finally, the third section is something about urban health that we have to recognize, that it is about governance. It is about accountability. It is about the political economy of the issues. Because we can talk a lot about diseases and environmental risk factors and a lot of other issues, but if we don't address this, this is never going to happen, because it does bring in the mayor, it brings in the governors, it brings in the community together to develop those solutions. It brings in decentralization issues within a country, and that is going to have to be the pathway forward to bring all of this together. So the report actually presents some very and unprecedented data synthesis that we've never had before. The first is to point out something which is called the Urban Health Index, which is one of the key tools that we developed with Georgia State University. And it is an index thinking of it like the Human Development Index, or the HDI, which is a basket of indicators. And here we used 9 indicators, and we tested it, and we did an analysis across 57 cities around the world. It is low and middle income countries because we use the DHS as the basis for that data, so you won't see developed countries on this one, although it has been used in both to highlight in places like Tokyo and Rio de Janeiro. The index itself is tailored to develop different types of indicators and can be used in any country or city around the world. Now, if you take a look for a moment at the dark spots, the dark is meaning that it's from a 0 to 1 scale, and the dark is being the worst situation. And you look at West Africa for a moment, which was very serendipitous because we didn't necessarily start out this way, but we have actually the West African countries that suffered the Ebola pandemic, is that it's no surprise to see that it reinforces the issues of very weak health systems, but also very weak urban health environments that then coincided with the situations that we had seen. And this is something that, as we start to look at where the cities are actually vulnerable, is fundamentally where the opportunities to act. But you have to have the information to understand where and how then to proceed, and then to disentangle that information. So it's one very useful tool to begin to look at different situations across different countries. So that tool is available, and we'll be talking about that a bit more tomorrow morning, which I'll discuss in a moment. The second fundamental part of this report is what we call the MDG scorecard. And this is something that has never been done, but is now in this report, which is that we have actually analyzed, using a variety of data analysis and secondary data, to look at the inequities and the impact of those inequities on the MDGs themselves. So this, when you look at this more carefully, you will see the differences in color representing the poorest and the richest quintile in a given city, and these are all different countries. Each one of those boxes is a different country. And there's a thin blue line that you can't see it probably there that indicates the MDG target. But most importantly, at the very top, you'll see a dark red area, a shaded red area, and a white area. The dark red area indicates where the target was actually met in urban areas. The shaded red one indicates where they was mostly met, and the white was where it was far from being met. And what's striking is that this actually has unmasked for the first time the fact that you cannot achieve and could not have achieved the MDGs without addressing the urban poor, and particularly that the urban poor were left behind. And so that understanding this now in a different way is to look backwards, because the MDGs did not collect equity data. This is one of the biggest problems that they had. So we've done this for each of the 8 different MDGs that you'll see there, and I think it will be very useful to think about understanding those inequities and what the impact would have been. And it's by each of the MDGs. The second is that looking forward in the future is that, as I mentioned, universal health coverage is the new major approach for not only the WHO and the World Bank and member states, but is actually now a target. And it's basically universal health coverage combines the coverage of services with universality, as I mentioned, and the financial aspects. And so here we've created a dashboard using a set of indicators that are now being discussed in the UN and with member states as to how we're going to track UHC, but against the different countries. And there's a tool for thinking of as a baseline for the future when you're actually thinking about tracking and planning, where we're actually looking at both the darker shadow, the black shadow there, is the level of inequity in a particular country against that indicator. And then the coverage is the size of the circle from the lowest, the richest and the poorest quintile. So when you have that darker, when you look at piped water at the bottom, that's starting to show the fact that we have a really big problem with access to piped water in homes and clean water supply, as was mentioned by Professor Haynes earlier. But here's a demonstration, and actually in an urban environment, where it's a real problem. And then as we go through each of these, you can look at different countries and to see where they are today. It'll be interesting to see where we are 15 years from now. And so basically for inequality analysis, we also have a lot of data there that each of those bars is a different quintile for a different country for a specific indicator. And so you can start to see and to map out that information. Now we've developed a set of tools to help cities collect this information, which is not just data, it's actually community participation in the prioritization process that's built in. This is the Urban Heart process, and we can discuss this a bit more. But that inequality analysis is in the report. But it's not just about data. It is fundamentally about solutions. And this is something that this report also, very much a departure from 2010, that we've heard that we've increased the awareness about the issues, but it is actually now identifying what are the solutions. People need to know what to do. Now, this is very difficult to do the science of trying to do multivariate analysis about saying this intervention is going to be better than this one. It's almost impossible to do. But there are a great deal of evidence and case studies about what is it about housing that we can actually work on together, or what is the impact between transport that you've already heard of with respect to air pollution, or with respect to mobility, or how is it about an elderly person who can actually walk across the street of 5 different rows of traffic, can they actually get to the other side, or disability issues. So there's a whole set of issues of understanding, but ultimately it's about trying to find a common language so that the health people and the urban planners and managers can actually find a way together to have that conversation, because until now it's been very, very difficult, and it will be difficult. But this is the challenge ahead of us, and this report for the first time, particularly from WHO, which is often very health-oriented, is actually looking beyond to really bring these sectors together and to understand the different aspects ranging from infectious diseases, non-communicable diseases, water and sanitation, transport, including road safety, which is an area that WHO has done a great deal of work on, housing, climate change, and safety is about violence. It's about the homicide rates, and it's about violence as a public health issue, and we've actually documented a lot of the data from around the world. So there's a great deal in the report that you will find in these areas. And so there are just a few photos to pull out just to give a few examples that this is an urban food garden, and there's a variety of different examples of this. This is from Philadelphia, where there's a whole healthy program there, which is both on NCDs, but also looking at exercise and a lot of other types of programs. And these are all individual studies that have examples that provide you a lot of the input as to the different strategies that have been used. We can think also about the piped water issue that I've mentioned, and this is from India, obviously, where for the first time this woman had piped water in her home. And when you consider, again, those numbers of 1 billion to 2 billion people living in urban slums, you start to really understand the magnitude of the impact that this has, from everything from diarrheal disease control to basic health outcomes in the home. And you can look at it from ambient air pollution to a whole set of issues, as you can imagine. In London, this is a bicycle garage where it prevents the theft on the streets. So it's not just having the idea of bicycle lanes, but you have to think through the problem in a very coherent and a very sophisticated manner. And so there are lots of those types of examples that are brought out. And finally, in the report, we have this governance chapter where one of the case studies is here from, I don't know if James Coburn is here, but from Richmond here, where there's a health and all policy example of looking at health inequities, but then trying to apply what we call this health and all policies approach to bringing together the different sectors and looking at both the negative impact of different policies on health and the positive opportunity for that. And so that this is a way forward. But I wouldn't use the word health in all policies necessarily, because it's very hard to translate that to another sector without feeling like you're not really speaking to them on equal terms. But fundamentally, it's been done in many different areas, and it's finding those examples and those solutions. We have the frameworks, and this report actually brings it together. And so I think this is the last slide. Okay, so we have an infographic that brings this all together. That's at the executive summary, and is a freestanding one as well that helps identify some of the different solutions. And so you can't see it from above there, but we can look at it from, again, the numbers and the data that really presents the argument for decision makers about why to act, and really looking at it from a disaggregated perspective, because that's what planners and decision makers are going to need. It is looking at basically the cities being planned for health. What are the interventions? What are the potential impacts for those interventions? What's the opportunity there in front of us? And then really thinking about a new vision for health. Now, this very long, I'm sure you'll memorize it, is where you can find the report. However, it's very much simpler than that. You simply need to go to the who.int website or go to our Kobe Center website, and you'll find it there. But the report will have both the data visualizations, which are very interactive data visualizations that will be available, but there's a lot more information, a lot more resources, and as I said, it's on the ISUH conference. And my final commercial is that, if this has been of interest to you, is that come tomorrow morning at 8 o'clock in the morning, to 9:40 in the morning, in the Mendocino room on the 25th floor. Please take notes, the 25th floor of this hotel, where we're going to take a lot more time to take apart the report in a great deal more detail and to give you an opportunity to interact and discuss it with us. But I think there's a wonderful opportunity in building on what Professor Haynes, Professor Kwan have mentioned, is that this is an amazing moment in time in history, and I think we then can collectively move forward and to act. And with that, I'd like to thank you very much again to Joe and to the team.
Very rich, rich food for thought, and now we're going to have real food, and I think some libations in the back, but our speakers will be available for individual questions, and they're all going to be appearing tomorrow as well. They'll be available to you as a conference. So Doug, do you want to wrap up? Doug? Doug? Doug and Shamim are having such a good time. Doug, do you want to wrap up, or?
Just to say that, the reason for doing this is to encourage networking, collaboration, and so forth. Enjoy yourselves at the reception. That's exactly what we want to do.